Okay, cool. Thank you guys. So yeah, the topic for today is hemoptysis. I'm Sai Choudhury, one of the EMI third year residents. Special thanks to Dr. Galliano, Dr. Wong, Dr. Bailey. So just jumping right in, hemoptysis is one of the most common complaints that's actually seen in the outpatient home setting. Depending on where you're at, there's also up to 10% of hospital admissions for hemoptysis. Uh, Massive hemoptysis is actually pretty rare. Worldwide, TB, mycetoma tend to be the most common etiologies. In the United States, the most common etiology would be malignancy, lung malignancy. There are a minority of cases, up to 5%, that are iatrogenic following instrumentation. But again, uh, only a fraction of these would be considered massive hemoptysis. Now, when it comes to definitions, minor hemoptysis is considered to be less than 100 cc's of blood expectorated within a 24-hour period. Massive, it's you'll see a lot of different definitions. Most people say, you can kind of know it when you see it. If you try to quantify it, generally over 600 cc's in a 24-hour period, or more than 50 cc's per episode. A newer paradigm is actually kind of classifying it as, is this life-threatening or is it not life-threatening hemoptysis? And important considerations would be briskness of bleeding, um, patency of the airway, and your major concern here would be asphyxiation, as opposed to exsanguination. Now, just going through the complications, right? You only have about 150 cc's of anatomic dead space before you actually reach parts of the lungs that can participate in ventilation and gas exchange. So this, as soon as you start having hemoptysis, you start getting airway obstruction that occurs, and then intrapulmonary shunting. So you're perfusing, but not really ventilating these alveoli. As a sequel of that, you start getting hypoxemic, um, and unstable gas exchange surface can usable gas exchange service can rapidly decrease. As you go into further respiratory failure, you start becoming hypercapnic and hypoxemic. Um, and this can start affecting your myocardium, and you go into peri-arrest and then a PEA arrest. Now, why aren't we as concerned about shock? Even massive hemoptysis volumes, you'd get about 300 to 600 cc's. They're usually not enough to cause exsanguination, and the lungs can fill with blood before total blood loss is hemodynamically catastrophic. Other things that you need to consider, aspiration into the contralateral lung that can worsen your shunting, airway reflexes. You can have laryngospasm, coughing that can also impair ventilation. Vagal stimulation can also contribute to bradycardia, making your patient more unstable. And you want to keep in mind the patient's underlying lung disease. If any, they might have a reduced reserve, more prone to accelerated hypoxia. Now, what is the pathophysiology of hemoptysis? So over time, due to whatever reason, you have inflammation, hypoxia, or even neoplasia, you get a proliferation of bronchial vasculature via secretion of pro-angiogenic growth factors such as VEGF and angiopoietin-1. These new vessels are usually thin-walled and fragile, and they're getting exposed to actually systemic arterial pressures, and so they become prone to rupturing into the airways, and that's how you get the hemoptysis. Now, if you look at the diagram on the right, um, this kind of breaks down the likely arterial source of hemoptysis based on where you're seeing parenchymal hemorrhage. So if you look at the diagram on the left first, it kind of splits the lung into upper and lower hemispheres, with the little a being the bronchial arteries. These are the most common source of hemoptysis in about 90% of cases. And that's usually what's being evaluated when imaging happens. Um, in the upper lobes, though, you can also have bleeding from the subclavian artery and its branches, including the thyrocervical trunk, axillary arteries, and then lateral thoracic arteries. And then as you go lower, you might have involvement of hemoptysis from the intercostal arteries, your internal thoracic arteries, as well as your inferior phrenic arteries. Now, when we go into the etiologies, there's a broad bucket where these where hemoptysis can come from. Generally, the most common reasons are due to bronchoalveolar inflammation. These are your necrotizing pneumonias, bronchitis, bronchiectasis. In children, the most common cause would be cystic fibrosis. And as I mentioned earlier, in the United States, bronchoalveolar neoplasia is the most common etiology, about 23%. When it comes to malignancy, primary lung cancers are more likely than metastatic. Squamous cell being more prevalent than adenocarcinoma. Things that complicate prognosis would be cavitation prior to the episode of hemoptysis. Um, Additional etiologies also include pulmonary vascular disease. So this is where your PE comes in, your vasculitis, onco-mediated or anti-basement membrane. A rare cause that I thought I would mention would actually be catamenial hemoptysis. So this would be a rare manifestation of patients with thoracic endometriosis syndrome. So patients with endometriosis, only 2 to 10% of them have TES, which is where you have functional endometrial tissue growing in the lungs or bronchi, and these can shed during menses. And a fraction of those patients will have catamenial hemoptysis. And just kind of reviewing the general pathophysiology again for these. When you have inflammation, infection, you have vessel wall damage. Tumor invasion can erode directly into these vessels. Chronic lung disease, you'll have hypertrophied, fragile bronchial arteries, and you can even have vascular abnormalities from underlying aneurysms or AVMs. Now, how are we assessing these patients? So more so in terms of uh, initial assessment, you want to make sure that this is actually hemoptysis. So you have mimics, right? Is this upper airway epistaxis from the nasopharynx, or is this like a GI issue, hematemesis? Other factors to also help in your decision making would be time of onset, volume, and rate of bleeding to help risk stratify patients. There's a study with around 1,100 patients that looked at hemoptysis along with factors independently associated with increased mortality. Patients received 1 point for chronic alcoholism, pulmonary artery involvement, hemorrhage affecting two or more quadrants of chest radiograph, and they were given 2 points for aspergillosis, cancer, or need for mechanical ventilation. Now, if you had a cumulative score of 1 point, there's a 2% chance of increased mortality, whereas if you had 7 points, there's a 91% chance of mortality with massive hemoptysis. 80% of patients with malignancy-related massive hemoptysis will also endorse a history of sentinel bleeding episodes in the days or weeks leading up to presentation. So it might also be helpful to ask about that. Other things to look at, do they have any recent procedures, recent chest tube, a bronch or a diagnostic biopsy? And are they on any anticoagulation? Are they prone to coagulopathy? Another important aspect is localization. So you want to get a chest X-ray on these patients. The sensitivity isn't too great, but it can help you with figuring out if you have opacities already. And that'll come in handy when it comes to positioning these patients. Ideally, you want to get a CTA chest with these patients, and it's a delayed phase study. So not a PE study, because remember, 90% of these cases are from arterial circulation, specifically the bronchial arteries. And then there is bronchoscopic evaluation. It can help identify where lungs are bleeding from, but not necessarily localize the exact arterial origin. When it comes to management, it's you're in the emergency room, a patient comes into CCT with hemoptysis. It's your typical ABC oxygen, ABCs, oxygen. I'd get an end tidal, put them on a monitor, two large bore IVs. We're maintaining an MPO status. You want to figure out, is this patient stable or unstable? Now, let's assume that, if they're unstable, then you have to address the ABCs, and we'll get to that. But let's say they are stable, you can get some labs for them. And the lab should be aimed at answering three big questions quickly, right? Is this patient bleeding? Are they coagulopathic? Do they have an underlying infection, or could this also be a systemic autoimmune or other underlying cause? So labs I would recommend probably CBC, hemoglobin. You want to quantify the severity of blood loss, platelets to identify thrombocytopenia, white blood cells count. You want to make sure that you want to suss out if they have an underlying infection. Coagulation studies, again, coagulopathy is a big theme here. Type in screen, anticipating if they might need blood transfusion. And then I'd probably get a comp. You want to assess renal function, also liver function as well. That can also contribute to coagulopathy. If you are suspecting infectious workup, it'd be reasonable to get, gram stains, cultures, TB, acid fast bacillus smearing cultures, and then viral testing if you think it's warranted. And you can also kind of send off some autoimmune markers as well, ANCA, anti-GBM, antibodies, ANA. Um, this is all for like undifferentiated hemoptysis. So a patient comes and you don't know what's going on. Uh, you can set a D-dimer again for PE. It's not specific. Liver test we talked about, and then also a UA. If you see hematuria, you might be worried, is this patient having some sort of like pulmonary renal syndrome? When it comes to imaging, we talked about the chest X-ray, CTA. Um, when it comes to positioning, this is where the chest X-ray can be helpful if you have time. If you see opacities on one side of the lung, it's safe to assume that they're bleeding from that lung. So you would want to keep the bleeding side in the lateral decubitus dependent position. Um, then after that, thinking about, does the patient need bronchoscopy or surgery, which we'll get to. So let's say they're unstable, right? Or you're having concerns about their airway. When do we want to intubate these patients? So the important thing to remember is an ET tube has what, maybe like a diameter of 9 or 9.5 millimeters as you get to larger ones. A native airway is actually about 15 to 25 millimeters. So you lose a great bit of volume. Um, Things that might want you to intubate these patients would be if they're unable to expectorate efficiently, they're not clearing their airway, if they have, depressed mental status, if they look like they're going into impending respiratory failure, or if they're, if you're worried that they're peri-arrest and they're going into cardiopulmonary collapse. On the right, we have a view of the carina in a patient that had a right upper lobe tumor hemorrhage, and they were placed in a dependent position after having left main stem intubation, and then they were transferred to operating room for rigid bronch. Now, how do we intubate? So you guys, I'm sure, have all heard of the SALD method, suction-assisted laryngoscopy, and airway decontamination. So I'm going to just pull up a quick video. Um, are you guys able to hear the audio on this or no?
I don't hear it right now. Are you
You
sharing your
don't.
audio?
I think so. Okay, I can, because I know we're kind of in like a little bit of a time crunch. I can post the links in the chat, and if anyone's interested, they can take a look. But just briefly going over quickly the method, right? The salad method, you basically are going to have a large bore suction catheter. So for us, we have the Ducanto catheter. Um, and you have it in this like overhand grip uh, in your dominant hand, and with the non-dominant hand, you're using your laryngoscope. And basically, you first place the suction catheter in to kind of suction out any soiling in the airway that's present, and then you're advancing the laryngoscope until you get into a good position. For your typical intubation. And then after that, you kind of tuck the suction catheter laterally to the laryngoscope and park it in place, so that way you're always suctioning ahead of the lens, and then you can proceed towards your typical um, intubation with your ET tube. There is a bit of a debate about, DL versus VL, like which one's better. Sackles et al. Is a prospective observational study that kind of assessed first pass successful intubation for a soiled airway, and they found that, soiling of the airway significantly reduces first pass success for both devices. So the GlideScope in a clean airway, you had a 91% first pass rate, whereas 81% in a soiled airway. And if you're doing DL, it's 76% clean, whereas 66 soiled. The decrease in success was similar for both techniques. And so their statistical analyses were confirming that airway contamination independently lowered success rates. Now, if you do use the SAD technique and your VL lens is obscured, you're going to have to convert to DL. So that's something to keep in mind. So now let's say we were able to get into the airway, right? You want to make sure that prior to prior to setting up, you have a large diameter ET tube, right? So this is 8.5 millimeters or greater. And what this is going to do is it's going to facilitate your suctioning and bronchoscopy. Dual lumen ET tubes. We don't actually have those here, but they are difficult to insert. They don't actually allow flexible bronchoscopy, which might be one of the treatments for actual hemoptysis. And they have a suboptimal clot extraction, so it's not really ideal. Uh, Bronchial blockers are what's recommended. And I just spoke with Dr. Albermani. He said County just got a package of bronchial blockers, so ICU does have them. Um, but the way it works is if you look at the diagram on the right, um, it's basically describing airway control in massive hemoptysis. So in figure A, um, we're using a large bore ET tube to secure the left main stem. And what this can do is it can accommodate a therapeutic flexible bronchoscope with a large working channel that can basically suction out any spilled blood. Now, B is why the double lumen tube isn't great. Um, Basically, they both have small lumens, and you can only have passage of a smaller pediatric bronchoscope, and that's inefficient in extracting clots. And so what happens is you have right-sided hemoptysis going on, and it can actually spill into the contralateral lung, and you have aspiration in that side as well. Um, and then you're unable to basically aspirate these clots. C is a situation where you want to isolate the right lung. Um, and so here, a bronchial blocker can be helpful. You pass the blocker through into the left main bronchus, and it includes hemoptysis from the left side. And then the side ports in the flexible bronchus can basically be used to ventilate the right lung. And then let's say you have left-sided hemoptysis again. You can also use a rigid bronchoscope. And basically, the rigid bronchoscope itself can block off the right side of the lung. And it also fits tools to kind of aspirate clots from the left side as well. Now, flexible bronchoscopy, right? Once a patient's intubated, it's actually recommended that you do immediate flexible bronchoscopy with a therapeutic bronchoscope to clear the airway of clots. As we discussed, this can improve gas exchange and ventilation. It also allows for you to see where the patient might be bleeding from. And then once the airways are free of blood clots and the bleeding source has been identified, you can then consider mainstem intubation of the non-bleeding lung, as we mentioned, to kind of avoid a contralateral spillage and aspiration. Now, it's important to note if you try to mainstem intubate the right bronchus, what happens is the ET tube cuff is actually going to occlude the right upper lobe bronchus. So that's where the bronchial blocker would be helpful in terms of basically occluding the left bronchus, so you can avoid that and still ventilate the entire right lung. Another problem with with using the bronchial blocker would be that if it were to get dislodged, it can actually move proximally into the trachea, and then you'd be blocking ventilation to both lungs, which is something that would not be helpful. Um, Now, what else can you do once you are doing flexible bronchoscopy? For the blocker itself, I'm sorry, I forgot to mention, for the blocker itself, it does have this specialized adapter that allows you to ventilate the patient while also doing having side ports for the bronchial blocker and the flexible bronchoscope. Um, um, so what are some of the interventions that you can actually do once you're doing flexible bronchoscopy? Now here, there is use of ice saline, which can help in cases of minor hemoptysis. Vasoactive agents are actually more controversial. Endobronchial epinephrine and norepinephrine have been used, but there's no consensus on like the dosing, and the concentrations can vary depending on where you're working. Um, and then there's also, in contrast to ice saline being relatively inert, these vasoactive agents can also precipitate like coronary vasospasms and arrhythmia. What about rigid bronchoscopy? So, as we looked at the diagram earlier, rigid bronchoscopes can actually selectively isolate either main stem bronchus while allowing for ventilation of the non-effective lung. It can help facilitate removal of large clots, as well as accommodating many instruments. Uh, for some of these other techniques that I didn't really get into, there's electrocautery, argon plasma coagulation, and YAG lasers. These are ways to try to achieve hemostasis once you identify, uh, excuse me, once you identify the endobronchial source of hemoptysis. But also important to remember these are all thermal techniques. And so when you're exposing these patients to oxygen, you can have a spark that results in endobronchial fire. So you have to be super cautious when using thermal ablative methods. Again, we wouldn't be doing any of this stuff. This is just like for our knowledge in terms of, what are some therapies that could be done. And then furthermore, there is an option for airway stenting, and this is mostly for palliation in setting of like obstructive tumors. Now, in terms of ventilation, once these patients are actually intubated, like what are our goals, right? So our goals are to maintain oxygenation ventilation, which they weren't able to do, hence why they had to get intubated. Prevent aspiration into the contralateral lung, and this is where the positioning comes in and getting that chest X-ray to kind of figure out, do they have opacities? And then also achieving hemostasis. So this would be, get optimizing visualization for bronchoscope so that way you can go in endobronchially and extract any clots and try some of those topical temporizing measures. Additionally, another concern with ventilation is you're starting to give positive pressure, so you want to actually avoid worsening of the bleeding if possible, and this is by trying to limit how high the pressures are, as high pressures can actually dislodge clots. Now, in terms of the actual mode, pressure control ventilation is actually favored, and again, it's to limit peak airway pressures. You want to do a lung protective strategy, so low tidal volumes, 4 to 6 cc's per kg of ideal body weight. Again, this is going to help reduce the airway pressure and bleeding risk. Low to moderate PEEP, so that's like 3 to 5 centimeters of water. Now, if the PEEP's too high, you can actually increase bleeding by raising intrathoracic pressures, and you're going to impair venous return. But if the PEEP's too low, then you get atelectasis, and you can like worsen shunting and hypoxemia. Um, what about FiO2? You can start high, 100% during active bleeding and bronchoscopy, and then titrate down once stable. In terms of respiratory rate, you can adjust to maintain adequate CO2 clearance. You don't want to excessively like hyperventilate these patients because again, it can cause air trapping. A lot of these patients have pre-existing lung disease and increased airway pressures. Um, and so we're willing to tolerate a permissive hypercapnia. And again, you want to keep your plateau pressures below 30 centimeters of water. Other things we talked about, the lateral decubitus positioning, so bleeding lung down, um, early lung isolation ventilation. So this is when we get our ICU colleagues involved. They can actually shift this to single lung ventilation, even ECMO in extreme refractory cases. Okay. So what about some treatments that are more evidence-based? So tranexamic acid actually has a role in hemoptysis. So there are a couple of RCTs that are highlighted. Wand et al. 2018, they did a nebulized TXA RCT, and they found that if TXA was associated with faster bleeding control, 96% resolution by day 5 versus 50% for placebo. They also had a reduced bleeding volume starting early day 2. And it's actually critical for bronchoscopic management because 0% ended up requiring interventional bronchoscopy or embolization versus 18% in placebo. So this suggests that TXA may stabilize bleeding enough to avoid escalation, and it can also function as a non-invasive bridge or alternate to bronchoscopic hemostasis in non-massive cases. Bellum et al. 2016. This is an earlier study. This was more of like an RCT pilot for IVTXA. They also found a reduction in hemoptysis severity by day 2, and there's also faster symptomatic improvement versus placebo. So just in terms of like a practical clinical interpretation, TXA can temporize bleeding, improve visualization, bronchoscopy is later needed, and avoid bronchoscopy altogether in mild to moderate cases. But again, a lot of the evidence is limited to non-massive hemoptysis, and it's not really a substitute for urgent bronchoscopy in massive or life-threatening hemoptysis. Um, when it comes to how you would administer it, you can try 500 milligrams Q8 hours. If it's nebulized or IV TXA, 1 gram Q8 hours. It's usually one or the other. You wouldn't give both. Now, bronchial
Hi.
artery
Oh,
embolization.
sorry,
Yeah,
sorry to interrupt. We just have like a minute or two left. I want to save time for questions. So if you
sure.
want to share like your pearls on each slide and
Sounds good. Yeah, so just wrapping up, the BAE or bronchial artery embolization is actually, the most successful treatment for this. Um, Success rates vary from 70 to 99%. There are certain risks, as with any other embolization procedure, that you should be aware about. Exception would be a Rasmussen aneurysm, which we don't really see as much here, but it's a pseudoaneurysm from cavitary TV. And then some studies do show that, patients who do end up having BAEs in the setting of malignancy, it's unlikely to change their 6-month mortality. So while it might be like palliative, it's unlikely to be helpful in terms of their mortality. And then the last part is surgery. So surgery is considered for refractory hemoptysis. This would be cases of uncontrolled bleeding, non-malignancy related, or failure of embolization. And of course, like trauma indications if you're having chest trauma with pulmonary pseudocyst or laceration or tracheobronchial injury. These would require surgery. And the options include wedge resection, lobectomy, vascular repair. Now, just quick approach to management. You want to figure out if this is life-threatening or non-life-threatening. If it's non-life-threatening, this can all be figured out outpatient. If it's life-threatening, are they stable or unstable? If they're unstable, you want to intubate them to facilitate flexible bronchoscopy, and then imaging to figure out the etiology for definitive management. If they're clinically stable, then you can proceed straight to imaging, and then kind of the same thing, figure out definitive management. So just summary, you want to make sure it's hemoptysis and not something else. Prioritize airway and ventilation. You want to get your ICU, interventional radiology, interventional pulmonology, thoracic surgery, and your anesthesia colleagues involved. TXA has shown some benefit. Um, be wary of coagulopathies and correct. And then you want to basically prepare these patients for some sort of definitive management if possible. Any questions?